This is my list of potential conflicts of interests, getting honoraria for lectures. And this is my definition for hemorrhage. We're talking about fluids in hemorrhagic shock. And this is a situation where there's an absolute deficit, an absolute deficit of intravascular volume via the loss of blood. And you find probably different definitions for hemorrhage, but this may be the cause for the situation we are facing. And I would like to go back, rather than to studies, because there are not many studies, rather to the physiological basis, which is hopefully a common denominator between us all and our patients. So all we should probably have intravascular compartment, interstitial, intercellular one. And all these schemes, Matthias Jakob, who has been mentioned earlier. Physiological basics of our infusion therapy. An adult has about 45 liters in all these compartments together. But in the intercellular space, 30 liters are dissolved. And it is marked here with that green areas. In the extracellular compartment, about 15 liters could be found, and this compartment can be further divided into the interstitial space and the intravascular space, 3 liters roughly. And this is our target compartment, because there absolute hypovolemia in case of massive hemorrhage occurs. And this is, of course, our treatment target compartment. So in hemorrhagic shock, the intravascular compartment goes down, and consecutively tissue perfusion goes down. And I don't have to give you, as experts, a definition for shock. So our fluid strategy in this situation is, of course, to stop bleeding. This is the causal approach. This has to be mentioned first. We need the surgeon to put a finger on the bleeding artery or whatsoever. But then it comes to us, anesthesiologists, emergency physicians, to give fluid strategy, fluid therapy, to increase intravascular compartment and to increase, maintain, facilitate tissue perfusion. So a physiological basis for our strategy coming to a definition of infusion therapy is fluid substitution for extracellular losses via the use of crystalloids and volume replacement with the target of the intracellular compartment with bigger molecules. It's an end in between. Giving pure water, such as glucose, 5%, would go to the whole body. It is not helpful in our hemorrhagic shock scenario. Isotonic crystalloids go, remember, to these compartments here. We can use them for the ongoing fluid substitution that might be required for urine output, for example, but in the perioperative setting, in the elective setting, we know that these losses amount up to 1 milliliter per kilo per hour. This is not much. If we give more than that, and it has been mentioned earlier, it's not only a cosmetic problem, it's more than that. Hypervolemia is as bad as hypovolemia, and especially in the situation of hemorrhagic shock. It is so tricky and so hard not to give too much to end up in this dynamic acute situation in hypervolemia. Because this, and we have heard earlier about that, may deteriorate the glycocalyx, and giving too much destroys it. So we have to take care of the soft part, the soft layer of the glycocalyx. Now, the next option would be to use iso-oncotic colloids, which have their action intravascularly, especially and probably limited to the situation when the endothelial barrier is intact. And this should be the case, for example, in the early phase in trauma. We do know that iso-oncotic colloids, but also hyper-oncotic colloids, have a good volume efficacy going beyond 100%. So it's a plasma expanding property, and this is exactly what we need in this situation. Proof of concept, iso-oncotic colloids act intravascularly, so physiology seems to work quite nice in our patients. And please consider here in that file that Ringer's lactate, as an example for a crystalloid, has only a very, very limited volume effect below 20%. But volume efficacy is context sensitive. We learned that again from the guys in Munich. And they have shown us that in the situation, especially in a bleeding patient, the maximum volume efficacy can be gained from all our fluids we have on hand. And in the situation of hemorrhagic shock, of course, we need the fluid with the highest volume efficacy. I think that context sensitivity is very, very important. Therefore, I put it on the cover of probably the smallest book from the Unimed series, which I had the pleasure to edit, Colloidal Volume Replacement Therapy. So when it comes to massive or severe bleeding, then this shock situation may evolve. But the pathomechanisms that may further aggravate ongoing bleeding are multifold. And when we resuscitate via infusion therapy our patients, then another pathomechanism of bleeding may become othered and aggravate the situation. This is dilutional coagulopathy. So after infusion of fluids, you may end up with a clot that is very weak and cannot withhold bloodstream. This is coagulational coagulopathy. So the ideal fluid in this setting should act intravascularly with a good volume efficacy, but it should have, ideally, no coagulopathic side effect, and of course other side effects should be absent as well. So these are the three things we expect in this situation. Some of us use a one-to-one-to-one approach in severe or massive bleeding. And this means that you give around 600 ml into a patient, into a bleeding patient. The problems now about volume efficacy is the following. We do not know what the volume efficacy of FFP is. Coagulopathy, you can see that this ends up in a dilutional, hemodilutional problematic just by infusing a one-to-one-to-one approach. Harms and burdens? Well, we all know that red blood cell transfusion, but also FFP transfusion, trally, infections, there are major harms and burdens that need to be considered in this approach. The German-speaking countries, also back home in Austria, we rather use, instead of a one-to-one approach, a concentrate-based concept where we infuse our procoagulants in very small volumes of about 50 ml. So in our setting, where we target our procoagulant intervention in order to stop bleeding, measure number one, we need other things in order to bring the patient back from hypovolemia to euvolemia. So there, for us, the question is how to dose, how to target our infusion therapy. We know that more patients get killed, if you will, by lactate due to tissue perfusion compared to strong iron gap or chloride. But still, these things need to be considered in our fluid strategy, favoring a balanced approach, of course. In the first study, which was investigating trauma patients, severely bleeding patients in hemorrhagic shock, exactly the population we are now looking at, they found that a very important parameter, lactate, is cleared faster, with that blue bars here, when these patients were resuscitated by the use of colloids, tetrastarch, compared to the saline group with the green bars. So probably, when we consider lactate as a killer, they did better when administering the colloid. Looking at the targeting, the measurement things in the blood gas analysis, we have included this in our recommendations of the European Society of Anesthesiology, which has been published and discussed earlier last week and will be published hopefully soon. But what about the third aspect of our decision making, about the harms and burden? Colloidal patient safety issues need to be considered, and it is harmful to give too little, but it's also harmful to give too much. So there's a therapeutic window, and these things here, these side effects need to be considered, and it is definitely affected by the choice of the colloid we take. There are coagulopathic side effects going beyond hemodilution, and this holds true to many of the molecules we have. The strongest effects on hemorrhage come from dextranes, which we do not use a lot more. Pentastarch has more effects than tetrastarch and gelatins and albumin. But in the massive situation, in a traumatized victim, the maximum daily dose may be not true. Maximum daily doses have been set up for tetrastarch, for example, according to the licensing procedures. But if it's simply running out of the cut vessels again, what is the maximum dose that is still okay? Nobody knows. In the end, I would like to touch down very shortly on small volume resuscitation, which has not mentioned so far. In an animal model, for example, in an Austrian group, they investigated the use of hypertonic saline, 7.2%, and compared it to other colloids. And they found that blood loss was lower. However, in patients, we do haven't these good data. When you look into the outcome data, for example, in these two studies, looking either at shocked patients with blunt or penetrating trauma or with traumatic brain injury, the results were rather negative, with no increased mortality, but rather an increased risk of dying in a subgroup that didn't need any transfusion later on. So probably this may be harmful for our patients, probably because of the high loading of chloride again. So here the books are not closed, but the major randomized controlled clinical trials have been stopped preterm because of these situations. So my conclusion is our strategies are heterogeneous. Fluid concepts, but also our procoagulant concepts, and this is important in hemorrhagic shock. A pathophysiology-based infusion concept could combine balanced isotonic crystalloids and iso-oncotic colloids. Hemodynamic monitoring will be the issue later on in further detail. I would like to highlight that hypervolemia should also be considered in the severe bleeding situation, and the monitoring of other side effects need to be considered. There will be a meeting, the Fracta meeting 2013. I will have the pleasure to chair together with Monty Myton, who will come later on. If you are interested in it, where we will consider all these aspects, please save that date. And if you want to know more about bleeding management per se, please go to my website. It's free of charge, www.perioperativebleeding.org, and get some CME points, if you will. Thank you very much.